All right. Hello, everybody. We're gonna do take two. I will start Corey having to come up here and introduce people bit by bit since we've already introduced the special session to everybody. But for those of you who don't know me, my name is Robbie. I am a clinician educator based out of UCSF, and I'm very proud to say that I'm joined by an amazing crew of CP Solvers team members on our live virtual morning reports. Well, I will acknowledge that almost every time on Thursday, I say it's a special occasion because it is. It's a special occasion because on every Thursday, I get to have the privilege of discussing with a CP Solvers Academy member. But today is very unique because, as you can all tell on Zoom, I'm not at home with my lush indoor plant collection and by the way, for all of you who watch this regularly, I'm sorry, there will be no dog barking. My doggy frequently makes his voice heard during these sessions, but today I have the privilege of being here at the University of Nebraska Medical Center, hosted by amazing folks, and a special shout out to Corey, who has made a lot of this happen, and many of you who have supported this wonderful visit so far. I wanted to take a moment to pass the mic to two people who will be joining us on CP Solvers to share the stage. And the first is to my co-discussant, Brett. Brett, I'll pass the mic for you to say hi and maybe tell the crowd a little bit about yourself.
Sure, yeah, thank you, Robbie. Really happy to be here. So my name is Brett Begley. I'm a third-year internal medicine resident here at the University of Nebraska, and born and raised in Omaha and continue training here in Omaha. It's a great place to train. Could not be happier. Next year I'll be chief resident, and I'm looking forward to being a general internist here in town in Omaha after that. So thank you so much.
Brett, I'm so excited to discuss together. I met Brett for the first time on Zoom a couple days ago, and then I saw your red. I can see it better now. I would love to see your. Yes, there we go. What's the story of the red tie? I have a guess there might be one.
Yeah, go Big Red. We're in Nebraska, so I had.
I love it. And Brett, I think your colleague to your Zoom left, Boomer, is also joining us here. Boomer, I'll pass the mic to you to say hi.
Hi, everyone. You'll see me leaning down so I can use the dragon to speak. My name is Luis Zuniga, but I go by Boomer. I'm a first-year internal medicine resident from El Paso, Texas. First time up in the Midwest was to come to Omaha. I loved my interview, so no regrets ever since. I'm interested in gastroenterology in the future and just really grateful to be a part of everything going on here today.
Amazing. I wonder if your chief colleague, Jack, might have had an imprint on you early on. I heard about his passion for GI. Boomer, I know this is a little bit of a vulnerable question, but I'm going to ask you anyway. Feel free to tell me not to. Can you tell us the story behind your name?
So my dad is very big on nicknames, and
Yeah.
I was a very large baby. So he was just like,
do you know how large?
Right around 10 pounds.
Wow.
So
that's
he
awesome.
said it's Boomer, and that's how it started, and that's where it is.
I'm so glad I asked. It's amazing. That's really cool. I would also love to take a moment to introduce our CP Solvers team members. So there is probably a good 10 or so CP Solvers team members here. I wish we could introduce them all, but two of them are playing an active role in this morning report. The first who's scribing is Parisa. Parisa, can I ask you to say hello real quick?
Hi, everyone. It is Parisa. I will scribe today.
Tell us a little bit more, Parisa.
I'm international medical graduate from Iran. Currently, I'm doing some translational research at Yale Medical School.
Amazing. Thank you, Parisa. And I think to your Zoom left is your colleague, Pushal. Pushal, do you want to say hi?
Hi, everyone. I think whenever I think of Omaha, I just remember Warren Buffett. He's one of my idols, and I really want to meet him sometime in life. So I'm really excited to have these CP Solvers over there today.
Amazing. It's a thrill to be able to look at you from this far away and not feel something personal. And I just want to call out, there's so many other people. Charlene is here, Yaz is here, Deborah is here. I don't know, it's a whole crew. I'm probably missing some people too. I also see Ibrahim and David here as well. And oh my gosh, there's too many. Anyway, what do? We do this every day. There are folks from all across the world who kind of hang out together and discuss cases on Zoom. And in most instances, as is true today, the case presenter works with a CP Solvers team member to kind of put their case together. And then two of us, often a CP Solvers core facilitator, and then either a guest from the CP Solvers team, or as is today, an invited guest, kind of tackle the case. So I know Boomer has prepared the case for us in aliquots, and Brett and I are going to just tackle the case. We have not heard anything about the case. Except maybe there might be a GI twist to it based on our presenters. We'll see. We'll see. But without further ado, we'll kick it off. We have a live audience here. I would love for you, as the case is unfolding, we'll stop at the bullet points and actually have you pair with your neighbor and kind of discuss the case now. Okay, alrighty. So Boomer, I think Teresa is ready for you. She will share the screen and we will have a virtual whiteboard up to jot down the details of your first aliquot.
Boomer, I think you're muted.
Thanks, Brett.
Yep. Give me one second. It changed my screen. I apologize.
Take your time. Take your time. No rush.
Okay. So for today, we have a 51-year-old gentleman with no past medical history who presented to our emergency department complaining of a 5-day history of daily fevers, headache, night sweats, shortness of breath, had 1 episode of non-bloody emesis, muscle pain, and generalized fatigue. He states that he feels like he has the super flu. He denies any rashes, joint pain, dizziness, cough, chest pain, palpitations, diarrhea, abdominal pain, or weight loss.
Is this a good point for us to stop? Is that what you had planned? Okay, I just want to make sure.
Sorry, I couldn't hear that one, but that's the end of the first aliquot.
Terrific. Okay. All right. So Brett, I'm really curious to tap into your thinking here. I think the thing that strikes me is the sheer number of symptoms, and I'll just kind of say them out more slowly. We have fevers, headache, shortness of breath, muscle pain, bloody emesis, fatigue, and a very nice kind of summarizing label of the super flu. I'm really curious if you were to tap into your sort of into the background thinking that's happening, where are you tempted to start?
Yeah, Robbie, absolutely. So the first thing that drew my attention is that this is a 51-year-old man who reports no medical history, but he's chosen to come into the emergency room today. And so that to me is automatically a red flag in my head saying, clearly something's not going on with this gentleman. Right now he's reporting an acute illness presentation of 5 days, but I'd be very curious to see as the case evolves, has there been anything more indolent as things go? I'll say when we're dealing with a collection of this many symptoms,
Yeah.
I want to try to simplify it in my mind, and at some point I think we'll be able to do that. But I think the first thing that jumps out to me is someone that's coming in with daily fever, to me suggests inflammation. And so kind of thinking down the inflammation pathway is where my mind jumped to first. And then these constellation of more systemic symptoms, I'm thinking back to, is this how his body is manifesting this underlying, perhaps inflammatory process?
I completely agree with that. I love how you acknowledge this triage dimension, where our patients triaging themselves is of enormous value. And I think the only thing that you're really can be confident about is that this patient is inflamed in some way, shape, or form. And I think that the semantic modifier of presumed acute inflammation allows you to be able to be confident about where to begin your thinking. And I think the open question really that we try to do with inflammation is to try to understand where it may be coming from. So I completely agree with that analysis. This person is inflamed, full stop, though there are some caveats to that. And then the question becomes, well, where is it coming from? I'm curious what your take is on that, given that you're getting so much signal towards so many different places. Where would you where would you start to begin to digest that aspect?
Yeah, it's tough. We've got an excellent review of systems, kind of being thorough and appropriately thorough, trying to get signal for different organ systems. I think, I'm kind of lowering the muscle pain and night sweats under the constitutional myalgia type symptom, but I think we have a signal here potentially for headache, which could be manifesting as a result of the systemic process, but also maybe a signal toward the central nervous system. But then we also have a signal toward the respiratory system with shortness of breath, potentially also, cardiac or thinking down that pathway. So those are maybe the two signals that I have here, but I think we need to proceed with caution before anchoring too quickly toward one or two organ systems, because it seems like this is quite a systemic thing based on his symptomatology.
Agreed. I completely agree. I think the fundamental problem representation is probably acute systemic inflammation. And then you're trying to figure out, is there a center of gravity that inflammation? Is it focused in one specific organ and then disseminating other places? And I think as a general rule of thumb, whenever somebody has acute systemic inflammation, we really have to be mindful of the fact that every single class of organism is at play. Viral infections, absolutely. Bacterial, maybe even fungal, maybe depending on the patient's epidemiology, which we don't even know, are parasitic. But the triage of the patient is a little bit of an insight into their illness severity. And if this patient comes in and says, I have acute systemic symptoms, and otherwise looks and is in terms of their vitals and exam pretty well, we render the label viral syndrome NOS readily upon those patients. Because we realize that when patients have these systemic viral syndromes, they're often viremic, and that's why they feel systemically crummy. And so I think the key part of solving this case authentically in real life is to look over and actually pay attention to if the patient is tachypnic, hypoxic, obtunded, confused, because all of a sudden we might have to skip over that step of, oh, you know what, the patient is just viremic, to entertaining more systemic, more virulent pathogens like bacteria, fungi, and parasites. But I'll share one insight. If you take the overly simplistic approach of breaking down infections into two categories, infections by commensal organisms or infections by exogenous bugs. An example, Staph aureus cellulitis being an example of an infection by something that normally lives on your body, encountering that with COVID, an infection that comes from the outside. As a general rule, infections coming from the world are much more likely to present as systemic diseases from symptom onset. In the viral category, flu-like illness, he said it. In the bacterial category, name an exogenous bacteria, rickettsia, Lyme disease, spirochetes. They tend to be systemic at onset. Fungal diseases, parasitic diseases. Whenever you're dealing with an commensal organism, they tend to be localized and then in advanced disease forms disseminate. So here, I think the leap that I would start to make now is this syndrome seems to be systemic at onset. And what does that make me do? That makes me dive deep into wondering if this is a bug that's coming from the outside world. But I'm cautious to make sure that we're not missing a commensal organism like metastatic Staph aureus infection that is disseminated widely. What will help us with that distinction? If the patient is systemically, if the patient has systemic symptoms, but is otherwise well appearing, that really pushes us to worry about something from the outside. Because when commensal organisms like Staph, E. coli, when they are so widespread that we're having to think about meningitis and pneumonia in the same patient, the patient's usually critically ill. So, Brett, to summarize, I love that you latched onto the core feature here. The patient is inflamed. We clearly have a systemic syndrome here. And I think the next question is to understand, is this a hectic systemic syndrome? Or is it systemic syndrome with a relatively benign consequences to the patient that will really help us sift through or what organisms we think about? Did any other thoughts or questions come up for you, Brett, before we hear more from Begley?
I think the only other thing I'll add, Robbie, is that when someone comes in with signs or symptoms of some sort of inflammatory process, we absolutely have to prioritize infection in the acute setting, because that's the life-threatening thing that causes inflammation in the acute setting. But as the case evolves and as our evaluation unfolds, if we are treating empirically for infection, we're trying to localize one, and that becomes more challenging, then I think going down other alternative causes of inflammation, such as malignancy, autoimmune, drugs, or a severe endocrinopathy or something of that sort, that also would come to mind. But I think we'll just track that as the case unfolds, prioritizing infection for now.
I think you're doing really well in a CPS discussion when you say the word track that very early on. Kudos to you, I love it. That was awesome. All right, Boomer, why don't you tell us a little bit more, please?
Absolutely. So for this gentleman's family history and surgical history, they were both unremarkable. He only takes a daily multivitamin. That's his only medication. However, with the onset of his fevers, he's been taking about 1,000 milligrams of acetaminophen every 4 hours for the last 2 days. When we try to put a number on it, he thinks maybe 6 grams per day. Social history for him, he's a world traveler. He's visited over 50 countries in the last 20 years. He's involved in construction work, and his hobbies include whitewater rafting and hiking. But his day job, he works in the metro area as an educator. He denies any tobacco, alcohol, or recreational drug use. And interestingly, within about 5 minutes of seeing this gentleman in the emergency department, he suddenly felt hot, nauseated, and then he just started to vomit. He then developed hypoxia, requiring high flow nasal cannula at 60 liters at 100% FiO2, became hypotensive to the 70s over 50s, so 70 systolic over 50s diastolic. He was given 2 liters of IV fluid, which ended up stabilizing his blood pressure, and he was sent urgently to the CT for imaging. And that's the second aliquot.
Awesome. Boom, I'm curious, were you there at this point, or did you get involved in the case later on?
I was actually in the room, and all of this happened right in front of me within about 5 to 6 minutes of meeting this patient.
Wow. What did that feel like?
It was my first time as an intern seeing someone that like as Brett mentioned, young, active gentleman, rapidly decompensate from 1 minute to the next. So it was a great learning experience that I was able to talk about with all the teams later on.
Yeah, I can imagine that. I appreciate you sharing that learning experience with the many people who are here now. Brett, I'm curious, you're in this acute situation. I think we would probably be now pivoting more towards trying to manage and stabilize the patient than we would be diagnostically. So what are your sort of stabilizing principles in this situation?
Yeah, absolutely. It sounds like the initial stabilization methods done by the team in the ER were appropriate and excellent. To your point, Robbie, there's a time to think and reflect on what's going on, and that is happening real time as well. But when the time course changes to like a sudden onset decompensating patient in front of you, then you also need to act and think about, how do I stabilize them? So to your point, even though the patient's developed hypoxia, and we sometimes, I think, have hesitation, do I give a patient who's acutely hypoxic or hypoxemic, do I give them fluid if there's a fluid component to the hypoxemia? The answer is, in my opinion, you support them with oxygen, but then you have to support that blood pressure. And I think that is potentially another sequela to your point, Robbie, of, is there a systemic syndrome where perhaps we have some vasodilation leading to hypotension or some other cause? Knowing that if you give fluid to stabilize the pressure, we always have backup plans from a protecting the respiratory system standpoint. I also agree that, it's very helpful that we got some additional history here, which
Mhm.
maybe we can tease out after the patient's vital signs have stabilized,
Yeah.
or once they're in the emergency department, I think or once they're in the, for example, the
Yeah.
care unit, if they go there.
Yeah, I think it's always very tricky in the simplified version of hypoxemia and hypotension to be open to the possibility of cardiogenic shock being the common unifying denominator, but the more common scenario being a separate pulmonary and hemodynamic process, or one that's united by sepsis and hypotension, and sepsis being a pulmonary origin. And I think here, close attention to the physical exam and point of care ultrasound will help you make that distinction. But I think you should probably default in most circumstances to trying fluids to help you either stabilize the patient or at least gain more clarity on the less common but maybe more morbid hypothesis of acute cardiogenic shock. I'm curious, like, based on maybe incorporating the additional data that you got in the social history, I think a patient has crossed our criteria for empiric antibiotics at this point. What might you be thinking about for antibiotics for this person?
Yeah, that's a great point. I think there is another signal perhaps for acute liver inflammation in the setting of potential accidental, it sounds like, over-ingestion of acetaminophen. We haven't quite quantified that yet. But that may be more of a non-infectious inflammatory signal. I think otherwise, not otherwise specified, I'm most concerned about the pulmonary system. And so it's someone that comes in from the community, acquired setting, even though they look really sick in front of you, I think perhaps covering for an infectious pneumonia, potentially leading to sepsis, might be a good choice for initial therapy. And so I would perhaps suggest something to cover for strep pneumonia, like a ceftriaxone, and then perhaps some atypical coverage with either a doxycycline or azithromycin. However, if we don't want to narrow down our tunnel vision too quickly and localize just to the respiratory system, it would also, I think, be reasonable to start even broader coverage, covering for things like Staph aureus in the bloodstream with vancomycin, and potentially some anti-pseudomonal coverage with cefepime as well. I think oftentimes we start big and narrow down once we've localized things. So if pushed at this point to select something, I'd probably choose a vancomycin and an anti-pseudomonal antibiotic, but have a low threshold to adjust that as the clinical course evolves and as we get new information.
I think that's absolutely superb. I think that the illness severity of the patient is going to push you to make less and less risks microbiologically. And I think initially you might have had a tough decision about what to start empirically, if even to start anything. But I think at this level of illness, it's probably hard not to. And I think an ongoing tension, Brett, is now the emphasis in terms of severity on the lungs as a clue to the underlying process, or is it a distractor because of the astute observations of the team by correlating emesis before this, presumably then now putting us in a situation where a patient has a distant problem that caused emesis, that causes an aspiration pneumonitis, and yet leaving us blinded to the true origins of this disease process. And so I think we have to be open to realizing the pulmonary dimensions are too severe to take a gamble, but have half a foot in the door that the emesis may be distracting us and falsely localizing to the lung. I think it's probably a little too high acuity to be esoteric about all the exotic infections one could be at risk for. But I'm curious if you can train your brain to ask what kinds of non-commensal organisms, we prioritize those appropriately, staph and pseudomonas, because you got 50 countries, Brett. What kinds of organisms would cross your mind authentically in a severe pulmonary syndrome with potentially an exotic or exogenous infection?
That's a good question. So naming the bug game here. I think we have some exposure to water, and so that makes me think about certainly a Legionella potentially. Excellent. If we're thinking about a pneumonia cause. If this person is discovered to have some sort of underlying immune suppression, then I might consider, something like a pneumocystis pneumonia. But again, I think it's too early to make that call.
Yeah.
The world traveler, that's a nice clue. I'm interested to see if that's more of just a red herring to tease us and thinking about more exotic, infections that we don't see every day here. So I'm probably just going to park it at that as the two things that come to mind immediately, and get back to you, Robbie, with what else you think about.
Oh, no, I think that's actually a superb answer. And I think I asked you an unfair question to kind of meanly make a point. I think it's impossible to answer that question. So what would I recommend instead is to actually have on speed dial antimicrobials that treat life-threatening exogenous infections. Because Brett, I think as you just demonstrated, I think it's not realistic to be able to recall all the exotic infections that can do that. So what do I do practically? Every time I'm in this space where I'm worried a patient has an exogenous infection, initially triggered by the initial systemic symptoms at onset, reinforced by the social history, is to think of 3 antimicrobials. Doxycycline for rickettsial infections and leptospirosis, ceftriaxone for typhoid fever, and then anti-malaria treatment, which I don't remember, so I call it anti-malaria treatment. I don't think the malaria is a prominent pulmonary syndrome, but I think things that would respond to ceftriaxone certainly can be, and things that would respond to doxycycline certainly can be. So I'm glad that our traditional treatment for pneumonia overlaps, and we were probably giving this person vancomycin and ceftriaxone. I think the nuanced decision-making here is, do you go with the Cithro to cover Legionella better, or do you go with doxycycline to make sure that you don't miss any of the atypicals? And I think there is no right answer to that in my mind, but I think it's important to realize that there is nuance to discussing what kind of atypical coverage we do. We usually view that as a less important aspect of treating patients with pulmonary infections, because it is. Most patients have our typical pyogenic organisms, but this patient, I think a thoughtful analysis of atypical coverage is going to be important. But why don't we get more information from Boomer to be able to have more data?
Sure. For our third aliquot, we're going to include the physical exam and the initial workup. So on physical exam, I was able to do this after he returned back from imaging. He was afebrile. Blood pressure was 120/71 with a MAP of 87. Heart rate 81. Respiratory rate was 17. And he was saturating 98% on 40 liters high flow nasal cannula. He appeared fatigued, flushed, moderate distress. However, he was alert and oriented to everything that was going on. Head, ears, nose, throat, all of that was pretty unremarkable. Conjunctiva were clear. Throat, oropharynx was all without any acute findings. No adenopathy and no JVD. So for his lungs, he did have fine crackles in bilateral lower lobes and no strong accessory muscle use with breathing. He was saturating well on the high flow nasal cannula. For his heart, he had regular rate and rhythm. No murmur was appreciated. He had 2+ pulses bilaterally and no peripheral edema. His abdomen was soft, non-tender. His skin was flushed around his neck and face, but otherwise no lesions visible on his body. And neurologic, he was grossly normal intact. For the initial workup, CBC was notable for a hemoglobin of 14.7, white blood cells of 6.4 with 78% bands, no eosinophils. Hematocrit was 43.1, and his platelets were at 35,000, whereas baseline is greater than 300,000. For his metabolic panel, sodium was normal, potassium was 3.6, chloride was 104, bicarb 23, BUN was 15, and his creatinine was 1.21 with a baseline of approximately 1, and his glucose was 102. AST was 100, ALT 114, ALK-Phos was 139, total bilirubin was 4.1, His acetaminophen level was negative, and chest X-ray showed multifactorial pulmonary opacities, infectious versus inflammatory per the read. And also he was started on ceftriaxone and doxycycline. So Brett, your first thought was right on.
Awesome. Cooper, I just gotta say that I know this is your first time presenting a case on VMR, but the pace at which you're presenting is awesome. The scribes are able to keep up with you. I think the one thing that they may not have been able to jot down was the Billy, which I believe was 4. Correct me if I'm wrong. Is that right? Was it? Yeah, total bilirubin of 4.
I'm having a hard time hearing you.
Oh, sorry about that. Wow, much louder. Was the total bilirubin 4? Is that right?
So his total bilirubin was 4.1.
Gotcha. And do you happen to have a fractionation, or do you want to save that for later?
There was no fractionation at this time. There was one obtained later.
All right, like presenting like a pro. I love it. Thank you. All right, Brett, I bought you some time, an extra 30 seconds there. I'm curious what you're making of the sum total of this data.
Yeah, this is all super helpful. Obviously, I think given the patient's initial sort of decompensation after the team saw him, I'm pleased to see that the blood pressure is now in the normal range. And then also, thinking about his subjective fever that he's reporting, at least at time 0, we've measured no fever. Thinking about the causes of hypotension with the physical exam, we do not see a JVD. We do have some pulmonary crackles, which are not necessarily the most specific finding in isolation for volume overload. And so I think that adds credence to the team's decision to give fluid at time 0, with down the road sequela being able to diurese the patient if you needed to later on. And I think, I was eager to see if there would be any skin findings in a clinical problem-solving case like this. It's helpful to know that there's not an overt total body rash or anything that's super characteristic. And as we jump down to the lab work, what's interesting to me is there's not a profound leukocytosis. In fact, the patient has a normal white blood cell count with bandemia, which I'm wondering in my head, does this patient actually have a relative leukopenia and actually should be more inflamed? And you couple that with the thrombocytopenia, which is pretty severe. That certainly, I think, needs to be explored further as we try to unlock the case down the road. And then saving some of the most, pronounced abnormal findings for last. This person has elevated liver chemistries and an elevated bilirubin. And so I think, despite a negative acetaminophen level, with that in the background, I think now we need to think pretty clearly about what sort of infectious syndromes might impact or inflammatory syndromes might impact both the liver and the lungs together.
Yeah.
And in particular, then thinking about how that might have sequela with thrombocytopenia along with that. I think trying to simplify all this data and maybe reframe a problem representation is, we've got this 51-year-old guy who's presenting with an acute inflammatory syndrome. And now we've learned that he has some pulmonary opacities, he has an inflamed liver, and he has evidence of thrombocytopenia. And I think that's kind of where my head has shifted this case at this point.
Yeah. I think oh gosh, I'm so impressed by how nuanced, balanced, and calm and collected your assessment is. It really is very cool. It's almost like you do this every day. Do you do this every day?
Not every day.
Not every day.
I do enjoy it.
Yeah, I think, no, I think it's really is inspiring to see. I feel like I'm solving this case with a colleague, which is awesome. I gotta say though, if we were, a group of us were talking offline about like how we try to make these cases as valuable as possible. And I think for me, I kind of just like hit a wall in terms of being, trying to avoid the morning report bias, which is now, you're like, wait, hold on, this is fever and cholestasis. And over and over and over again, that triggers in me the idea that this is cholangitis until proven otherwise. And now all of a sudden I'm like, wait, hold on. Am I dealing with a young person with biliary stone disease who lodged a stone in his common bowel duct, vomited, and now I'm sitting there thinking about his lungs when the real problem is that he has pus under pressure in his biliary tree. And then I'm like, wait, yeah, I should think about that more because Boomer wants to go to GI. It's probably not what I should do, but I am. But I'm curious, if you were to play devil's advocate and would propose a counter argument to that chain of reasoning, because I actually don't think it's what's going on here, and I can justify that. And I'm curious, it didn't cross your mind. And I'm curious if you would kind of dissect why we shouldn't be like, hey, fever, cholestasis, what are the counter arguments for cholangitis in this case?
Well, I try not to use eponyms too frequently because I think they're pretty esoteric, but there are a triad and pentad associated with acute cholangitis, which is something you can't miss and acutely life-threatening at time 0. What argues against an acute cholangitis picture in this patient is the fact that number one, his blood pressure is normal now after some fluid. Number two, he's mentating appropriately, and it seems like he's been mentating pretty appropriately this entire time, despite feeling pretty ill. And number three is, he does have a slight elevation of bilirubin, which certainly I think needs further exploration. But that classic triad of, fever, abdominal pain, jaundice, hypotension, and altered mental stat, I think that's the Reynolds pentad, if I'm not mistaken. That's pretty specific for localizing to the biliary tract in the setting of cholangitis. And we have some of those features, but not all of them, to where I would agree with you, Robbie. It's something to think about in passing to not miss, and thank you for bringing that up. But it didn't even cross my mind, to be honest with you, because of the mental status and the pretty benign abdominal exam that we got.
I agree with you. And I think that just reinforces, I'm so glad you said that, I'm on the same page with you. I think it just reinforces this concept of when people are systemically sick from a commensal organism, like Staph aureus or E. coli, and if they get this ill from a lab perspective or from a symptom complex perspective, their hemodynamic fingerprint is robust, and they will require a lot of resuscitation to work to ensure that they stay alive. And there's a marked disconnect between the depth of the thrombocytopenia, the degree of anemia, and our ability to kind of just like casually talk to this person now after the emesis episode. And I think in real life, it's so easy to gloss over that portion. But actually, proportionality picked up by one of our interns in Morning Report was the key to unlocking a complex case that we discussed yesterday. I think it's the key to now saying, I'm going to treat for regular old pneumonia. You might even extend your antibiotics to cover anaerobes if you're worried about cholangitis, but in your heart of hearts, you got to be like, this patient has a severe laboratory fingerprint, yet is not hectically ill. That is a tip-off that we really got to visit the exposure history. And I'm glad we already had that. But if you were in a busy ER where the patient was almost intubated because how sick they were, you might not do that. So, Brett, I think maybe a very helpful finding to focus in on is the thrombocytopenia. So when you're in the world of inflammation and your platelets are low, what have you done with that in the past, and how are you using that today?
So I think when you're in the world of inflammation and your platelet count is low, then I think that needs to prompt a couple things right away. So to me, the good Dr. Neumeister, who's a faculty member here, has a short list differential for severe thrombocytopenia that can be a life-threatening situation. For him, with extreme pronounced ITP, that's bleeding, that's one thing. ITP, TTP, nice. DIC, and then drugs, namely if someone's been in the hospital on heparin. Here I think the other things that you'd think about would be hemolytic uremic syndrome, or an atypical cause of that, especially with the viral, or not viral, but the systemic footprint that he presented with initially. Obviously, if someone has an exogenous organism causing a severe sepsis-like physiology, that can drop your platelets as well. And sepsis itself is, I believe, the most common trigger for DIC on its own. So I think getting some coagulation studies would be extremely helpful as we proceed. And then the other thing, of course, I think we have to look at a peripheral smear and look for schistocytes would be the next thing that's in my mind, while we get other, infectious data back.
Amazing. I love it. I completely agree with that checklist. And the approach that I share with my CP solvers friends who know it is I tell people to literally hold your breath until you have ruled out HIT, schistocytes, and blasts. So schistocytes, Hold your breath. Schistose, heparin, blasts, breathe. Do not breathe until you've done that. And I think here, not much heparin. Blasts, we were humbled this morning about how sneaky leukemia can be. And schistocytes, as you said, are profoundly important to exclude in this patient, though the degree of the hemoglobin here may make that the pretest probability pretty low. In general, when you're thinking about isolated thrombocytopenia, there's three broad localizations. Are the platelets low because of an issue in the environment that they're in? And that, Brett, is what you said. That's a microangiopathic hemolytic anemia. The problem is not the platelets, it's the blood vessel. The other localization is not the environment, but actually on the membrane of the platelet. And that's another thing that you said, ITP or heparin-induced thrombocytopenia, where there are antibodies that attack the platelet membrane. You can go in a step deeper, where infections can destroy the platelets itself. So if you're thinking about isolated thrombocytopenia, think about the environment they're in, the membrane, and then inside. Environment, MAHA, membrane antibodies, either specific ones like HIT or non-specific ones like ITP, and then inside, infection. And Brett, you said it. Pyogenic infections from sepsis are the most common causes, but there's a short list of infections that tend to cause disproportionate thrombocytopenia. And I think while we should hold our breath until we've ruled out schistose, heparin, breathe, I think we can now start to say, what is the CP solver schema for exogenous infections that cause thrombocytopenia? And I think that checklist will help us begin to start to make progress in this case. But I think that low platelets here are a very, very powerful clue. Within that schema, there are viral causes, bacterial causes, and parasitic causes. The bandemia here really pushes us to think about exogenous bacterial infections that cause disproportionate thrombocytopenia. And I think that is probably the most narrow channel to be able to solve this case. Any other points you want to make before we hear more from Boomer?
And not for me. It's more fun for me to listen to you, I think. So that was great.
Right back at you, my friend. But don't make me blush in front of all these people. Come on. Okay, just as a time check for everybody, after the next aliquot, we're actually going to go into breakout rooms on Zoom, and would love for all of you to just like share your thoughts and get the juices flowing. So, Boomer, I'd love for you to present the next round of data, and then what I'm going to do for everybody on Zoom is open up breakout rooms for 5 minutes for folks to share their thoughts, and we'll reconvene as a large group. All right, go for it, Boomer.
Okay, great. So for the next aliquot, CT chest came back with no acute findings, no PE. Respiratory pathogen panel was negative. His UA was positive for nitrites, small bilirubin, trace leukocyte esterase, and small amount of ketones. His PT and INR were mildly elevated at 13.8 and 1.2 respectively. His his DIC panel showed a D dimer of 15,000, a normal fibrinogen, no schistocytes on there, and a PTT of 32. His acute hepatitis panel was negative, HIV negative, blood cultures were obtained, a peripheral smear was ordered and sent, and I have the results for the next aliquot. His LDH was 459. His haptoglobin was less than 30. And what you all were thinking about with testing for other causes, his West Nile antibodies were IgG positive, IgM negative. Dengue fever antibodies were IgG positive, IgM negative. His IgRA for tuberculosis was indeterminate. And that was all we have for the next aliquot.
All right, perfect. Yeah, Brett, I'll give you like 3 or 4 minutes to think this through. I'll open up the breakout rooms for folks on Zoom, and folks here can chat amongst themselves, and we can do a little bit. Let's hit the record button again. There are a lot of amazing things in the room here, but only one person's opinion matters. Brett, what are you thinking?
No pressure, right? No. So at this point, I'm fascinated that this person has evidence of, at least some evidence laboratory-wise of hemolysis.
Yeah.
Severely diminished haptoglobin and an elevated LDH. Neither of those are 100% specific to a hemolytic process, but I think to your comment from the prior aliquot, Robbie, now we have to think about what sort of, I'm prioritizing bacterial syndromes can lead to this constellation of abnormal laboratory finding in someone that otherwise is hemodynamically pretty stable. So for me, given this unclear exactly where world travel has happened, the things that cross my mind are things like tick-borne illnesses, specifically. I'd be curious to see if this person has been to the Northwest for something like babesiosis. I think to your comment from several minutes ago, leptospirosis certainly can be a systemic syndrome that has a similar mapping. Depending on the degree of world travel, I think malaria can do just about whatever it wants, and a fever and a return travel, that's like the top three things by differential. So I'd like to see how recent that was, or kind of when this took place. And then other tick-borne illnesses outside of that, I would not cross Lyme disease off the differential. Ehrlichiosis, anaplasmosis. That's where my head goes first. Again, basing that a lot, putting a little bit, perhaps too much weight in the bandemia that we have. But I'm thankful this person's on doxycycline, and would be not unsurprised, I guess, if there's some fun twist where a viral or a parasitic clue makes its way for us to move forward. So
I think that's so well summarized, and I've never seen a case hint so much on fractionation of the bilirubin. Never, because if the bilirubin turns out, and by the way, Boomer, like amazing call to not give that out early to stretch our thing, right? Because if you Brett, like summarize this case as an acute febrile syndrome with cholestasis, thrombocytopenia, and acute interstitial nephritis is evidenced by pyuria and AKI and a relatively low potassium. That's lepto. And the pulmonary involvement could be DAH. But if you phrase this case as a patient with acute infectious hemolysis, completely different. So if the bilirubin turns out to be mostly conjugated, I bet we'll say, oh, I think that the haptoglobin is low because the liver's not happy. But if the bilirubin comes down to be indirect and is mostly unconjugated, we'll probably say the patient has hemolysis. So how about we fractionate that really, Boomer?
Yeah, so the bilirubin was fractionated to we got to redraw the next day. It was max of 7.8 and conjugated 5.0. So direct.
Awesome. So Brett, what are you thinking now? It's mostly conjugated. What does that do to your hypothesis of hemolysis?
I think it definitely weakens the hemolysis arguments a little bit. There is still, as you break down the bilirubin, there is still a slight elevation of the indirect hemoglobin too. I think the peripheral smear is something that I am very much looking forward to hear. So I think, but to your point from a minute ago is, as we're putting all the pieces together here, just the value of a simple test like a peripheral smear in certain cases, super helpful. So that's, my differential hasn't necessarily anchored in pen, we're still penciling in, but I think leaning more toward a liver dysfunction associated cause here, as opposed to hemolysis, but we'll see.
I think that's exactly right. And I think this case goes to show you how hard it is to diagnose hemolysis sometimes. You're seeing a case of possible hemolysis with a normal hemoglobin. The haptoglobin often takes days to come back, so it's tricky to use in real time. The LDH is very non-specific. The peripheral smear can be normal in about 50% of patients with hemolysis, so it's really, really tricky. And I think that the degree of the conjugation of bilirubin certainly supports the liver being involved in some way, shape, or form. But I love that you're open to the possibility the patient has liver issues and hemolysis at the same time. And I think that the cautious problem representation would say that this person has an acute febrile systemic syndrome featuring cholestasis and possible hemolysis with, I think, the smear being an open test to help us understand if there's a hemolytic component, and potentially as we trended the bilirubin, trending the UA to make sure there isn't a discordance on the blood versus RBC. But I think it goes to show you, we haven't really defined the syndrome with clarity yet. And I think it could be purely hepatic. It's unlikely to be purely hemolytic. And the question is it hepatic hemolytic overlap is the active question that I'm toggling between. And I agree with you, the hemolytic infections not to miss are primarily malaria and babesia. So I'll pass the mic. I know we're getting close to the hour. I'll pass the mic to Boomer for the next aliquot.
Yep. So for our final aliquot, finally getting your smear, Brett. I know this would have made it much easier for you, but so thick and thin smeared of his peripheral blood showed red cells with intracellular parasites consistent with Plasmodium falciparum. Unfortunately, there was no parasite load reported on the first smear. However, after 24 hours of IV artesunate therapy, there was 5.4% of parasitemia on the subsequent smear. Fortunately, here at Nebraska Medicine, we are an infectious, it's one of the things that we do exceptionally well. We have what's called a global fever panel, which can check for Plasmodium species, chikungunya, dengue, leptospirosis. So Plasmodium falciparum was detected, and it was negative for Vivax, Ovale, chikungunya, dengue, and leptospira.
Oh, Boomer, this is so educational. I think that the way you chose to present it and leave us in a dilemma about what the core problem was so well done. Thank you so much. Brett, I'm curious what your thoughts and reflections are now that we have a lot more clarity on what's going on.
Thank you for the peripheral smear, Boomer.
You're welcome. Sorry I had to hold it.
No, you're good. I harken back to the last time I had the opportunity to be on the infectious disease service here, and one of our awesome attendings said, as the pandemic has evolved, we haven't seen as many cases of fever in a returned traveler, at least here in Nebraska, USA. But that changed from my first month 3 years ago to more recently in 2023, and he made it very clear that fever in someone from a returned traveler to the United States specifically, malaria was the top 3 things on his differential. And that's where the power of just something as simple as a thick and thin blood smear can be helpful. And then on top of that, now we have the super expensive panel you can order, which is fun.
My reflections were, it was really powerful to, it's a very vulnerable space to be in, to like be sitting in a room by yourself, but knowing that you're projecting to many people who are like tagging into a skill that you work really, really hard to build, and you want to like do a good job at that. And I think to see how calm and collected you were from the beginning was really admirable, and to see your authentic solving of the problem without jumping to premature conclusions, and to outline the tensions that I think were felt. And I think it goes to show, this case I think goes to show you how defining the problem can be very, very tricky. And I think if we had called this a febrile hepatic syndrome, we probably would have been led astray. And your openness about recognizing that it could be labeled differently, as inferred really by the presence of the markedly low haptoglobin, and you're not letting go of the importance of the peripheral smear, I think define this case. I learned a lot from discussing with you, and I really want to thank you, Boomer, for putting this case together for us to learn from. I'd love to get your reflections, having taken care of the patient, of what it was like to take care of them in real time, and what you learned then, and maybe what got reinforced today.
Sorry, if that was to me, I couldn't hear the last part there.
Oh, sorry. No, yeah. What did you learn taking care of the patient?
Oh, I learned that, one, don't panic when someone is acutely changing in front of you. So that was a good intern lesson. Learned that, like Brett appropriately said, malaria can do what it wants, when it wants. In this case, it also had the hepatic involvement. And I learned to dig into different areas of medicine that I'm not as familiar with that we read and learn about in boards. However, in the middle of Nebraska, I was not expecting this diagnosis
Yeah.
my intern year.
And medicine will keep you on your toes in more ways than one. And I will emphasize one learning point, which is whenever you're dealing with exogenous infections, try to keep it simple and think malaria deficiency, ceftriaxone deficiency, and doxy deficiency. And I think it's a long, long, long way. But we have another guest to introduce, and that's Mary Kate, who's an intern here. And she was processing this case also as an unknown, and gonna come up here and share some learning points that you had.
Yeah. Well, one of my learning points was what you just said about, that's okay, that your go-to speed dial drugs in a case like this are doxy, ceftriaxone, and antimalarials. Think when you're thinking of so many bugs, it's nice to have that go-to in your back pocket. But I was just gonna say also, thank you for walking through that case. I think especially as an intern, it's always helpful to hear clinical reasoning in real time, and Robbie and Brett did an excellent job of how to walk through this broad differential. I think one of the other main points listening to this case that you brought up is when you're thinking of undifferentiated infections, it can be really helpful to consider broad categories of exogenous versus commensal, and the way that the patient presents can make you lean one way or the other. In this case, we thought a lot more about exogenous infections given the systemic presentation. I think that's a good teaching point that I hadn't thought about before. And then I also thought a nice thing, Brett did a really nice job of, as he got key data points, including like the thrombocytopenia, he didn't narrow himself down too early and still kept that broad differential, even though there was a lot of red herrings that could have easily narrowed you down one path. So thank you for the case.
God, you absorbed everything like a sponge. Traditionally on CB solvers, we actually have a designated person. Today is Kushal, who jots down the teaching points on the far right columns you see. Kushal, I managed time suboptimally today. So maybe instead of reading all the teaching points, maybe I can ask you to summarize the 2 of your favorite teaching points from today's VMR. I can't see you, Kushal, so I'll put you on the screen. I think we lost Kushal. Alrighty, well, maybe next time. We'll practice the learning points. Oh, there
Actually,
you are.
Hey, hi. So my favorite teaching point was what Brett said initially. If a person who was previously healthy and is visiting the ER with multiple symptoms, that's a red flag in itself. And the other one was to give the combination of drugs like doxy, ceftriaxone, and antimalarial, but also be flexible to change the drugs as our understanding of what's causing it is changing.
Amazing. I love that. Thank you for emphasizing those 2 key things. And thank you all for taking the time to join, and look forward to seeing you all in the future. Thank you.